So we're going to introduce our next speaker, and we really appreciate Ala coming in and helping out here and giving the next talk on Phakic IOL. So Ala Danzuri.
Thank you, Bill. Ladies and gentlemen, I am a strong believer in Phakic IOLs, and I'm very convinced that every time you can use the proper Phakic IOL for the proper patient using the proper technique, your patient will be much more satisfied than doing any kind of keratorefractive surgery. I've been doing this for 25 years, and I can tell you that, and everyone who is using Phakic lenses know the high satisfaction rate with the Phakic lenses. I was asked to put together some challenging situations with Phakic intraocular lenses. These are my financial disclosures. So I put them in under 4 groups, and we're going to go through them one by one. Maybe the more common, but the easiest to treat is to have Ametropia after Phakic IOLs. And because of the very high predictability of Phakic lenses, whenever I have a residual refractive error for a toric Phakic lens, I always look for the alignment, because one of the main reasons for not having a satisfactory refractive outcome after toric lenses is a misalignment. There are 2 available toric Phakic lenses, the Toric Artisan and the Toric ICL. If you have a misaligned Toric Artisan, it's easy to diagnose because you can see it easily on the slit lamp in the anterior chamber. Then you have to de-enclavate the iris and then re-enclavate it in the right position. And the advantage of the iris-fixated lens is that it cannot change its position in the eye. So it's the surgeon's responsibility to properly align an iris-fixated lens. It's not the lens mistake, it's not the patient's mistake, it cannot rotate inside the eye, so it stays wherever you put for the rest of the patient's life. For the Toric ICL, if you have a misalignment, this can be due to either a proper alignment from the time of surgery, and this happens when the pupil gets smaller during the surgery, or an undersized ICL can rotate inside the eye. So taking back the patient to the operating room, it's usually very easy to realign a Toric ICL under viscoelastic, and then you can easily rotate the lens in the proper position. And a tip here, if the Toric ICL is easily rotated inside the eye, this is most probably an undersized lens, and this will need exchange later on. Usually the patient presents with mixed astigmatism with a good spectral corrected vision, and do not ever try to correct this with the laser, because I've seen this couple of times with dramatic results. So realigning a misaligned toric IOL is the way to go. And of course, with the modern digital way of alignment, it makes it much easier for the surgeon. Now, what if the IOL has a wrong power? And this can be due to a wrong IOL calculation or a progressive myopia. Well, maybe many of the surgeons will think of doing a laser touch-up, whether you do a PRK or a SMILE or a femtoLASIK. But to me, the best option is always to go and exchange the IOL, because you want to preserve the advantages of inserting a Phakic IOL as opposed to a keratorefractive surgery. And taking an ICL out of the eye is very easy. You just need to grab the lens firmly from the thickest part, which is the junction between the optic and the haptic. Taking an iris-fixated lens is a little bit more challenging because you need to de-enclavate the iris, remove the iris tissue from the claw mechanism of the haptic, but this can be easily done, and the lens can be removed through the small incision, and then you can insert a new lens. The challenge here is that the optic of this lens is made of silicon, so it's not easy to have a good grip of this lens, but the haptic is PMMA, so you can hold it and just pull it out of the same incision. And then I usually need to do some counter pressure taking this lens out. So taking out an ICL is much easier. Now, the second category of complications are a little bit more dramatic. These are when the surgeon do not follow the proper selection criteria. This is one of the old Phakic angle-supported lenses, and I'm proud not to do a single case of angle-supported lenses in my career. But I'm facing these kind of cases with the angle-supported lenses that come many years later with corneal decompensation, and the only way is to do a graft on these patients. Now, with iris-supported lenses, corneal decompensation can still occur if you do not respect the critical distance, which has to be 3 millimeters or more from the endothelium. When we started doing these lenses in the mid-90s, in the early 90s, we did not have anterior segment OCT, and the company recommendation was 3 millimeters from the epithelium, which is wrong. I had to remove many of these lenses because of endothelial decompensation, and the advice here is if you have to remove an Artisan lens, do it through a separate incision. If you're going to do a phaco or endothelial keratoplasty, do it through a separate incision because this makes the surgery easy. Posterior chamber lenses, the worst case scenario is developing cataract that was relatively more common in the early designs in the 15 years ago. Now with the V4, it was much less. With the V4C, since the introduction of the central hole in my hands, I'm using this for 3 years now, and so far I didn't have a case of cataract so far. The third category is those with the poor visual acuity, poor visual quality after the surgery. A decentration of the anterior chamber lens may give incapacitating edge glare, and recentration has to be done. In a posterior chamber lens, usually the quality of vision is better because it's closer to the nodal point. The functional optical zone is larger, and this is a post-operative 1 month after ICL, and that shows you that the objective scatter index is exactly similar to what it was before the surgery, which means that with phakic intraocular lenses, we are preserving the quality of vision. The last category, which will be more and more common with time, because these people, remember, we are treating mostly myopic patients, maybe high myopic patients, and these people will develop senile cataract later on. And the main advantage of phakic lenses, in my opinion, is that you're preserving the cornea for the future. Today, we are having excellent outcome with multifocal lenses. You can imagine the advances 20 years down the road. These patients who have a phakic IOL today will benefit from these advances 20 years when they develop their senile cataract. So to conclude, management of challenging situation after phakic IOL, you have to treat the cause if possible, the repositioning, removal, or exchange of the lens. Endothelial keratoplasty is used in corneal decompensation cases, and always keep in mind that the majority of these patients will be, the majority of these lenses will be removed 20 or 30 years down the road, so save the cornea of these patients for the best possible outcome after phaco surgery in the next few decades. And thank you for your attention.
Yeah, so we were just kind of discussing the incidence of cataract formation. I mean, it seems like it has gotten lower and lower. What do you attribute that to, and do you think we have enough information about the newer models? We haven't really followed them that long. I mean, I saw the 0% incidence of cataract formation there.
I think the lower incidence of, the incidence of cataract was low with the V4B that was introduced in the early 2003 or 2004. In my hand, it was 0.5%, which is acceptable. But since I used the lens with the hole, I have no cataracts. And I think this is due to the more physiological flow of the aqueous through the center of the pupil, rather than having a peripheral iridectomy.
Right. So you think partially it's the peripheral iridectomy that was causing the cataract. That's great. Okay.
So we don't have any more aqueous entrapped between the lens, the crystalline lens, and the ICL.
That makes sense.
Perfect. Thank you very much. That was terrific.